All right, this is a presentation about correction of clubfoot deformity at all ages, starting from infancy all the way into adulthood. This is a cumulative experience of using treatments which are gentle, effective, as well as scientific, meaning chiefly they are based on the kinesiology of the ankle and subtalar joint. So let's begin with the famous Ponseti method in the treatment of clubfoot in babies. This is Professor Ignacio Ponseti at the age of 92. This is a photograph he sent us uh, with his emissary, Professor Jose Morcuende, when we conducted the first clubfoot conference in India at Akola in the year 2004 in the month of November at the Government Medical College. So when we have babies with club feet like this, the the Ponseti sequence and the method of casting with the Ponseti method has now obviously been adopted by most surgeons all over the world. It is indeed very effective, gentle, and it allows us with only a few serial casts to completely correct the deformity. This is not traumatic to the parents, it's not traumatic to the baby. The number of surgeries is kept to a minimum, and the process of applying the plaster cast is not painful, and the casts are applied with the baby on the mother's lap, frequently when the baby is nursing, and hence both the child and the mother are comforted, and there is no distress, nor is there. We can get very good correction of all the components of the clubfoot deformity, including that of the equinus with the Ponseti method, with or without a tenotomy. This is one more example of a baby who came to us in the first few days of birth, and all the deformities have been sequentially corrected. Here you can see the right foot is completely corrected out of equinus as well. So the Ponseti method consists of serial plaster changes, typically every week. It may vary from once in every 3 to 4 days to as late as once in 10 days in older children. No anesthesia is given, and the cast is always applied from toes to the groin. The sequence in the Ponseti method consists of initial supination of the forefoot. This is to help match the supination of the hind foot to the forefoot. So the hind foot is typically very supinated. So the initial forefoot is supinated by lifting up from underneath the first metatarsal. This is counterintuitive, and it is opposite to what was done in the kite method and previous methods of manipulation, in which we pronated the forefoot, which actually increased the cavus. So after initially supinating the forefoot, then we abduct the forefoot with counter pressure on the neck of the talus. Once the calcaneus is abducted and comes out from underneath the talus, which can be measured on an AP X-ray as AP talocalcaneal angle of approximately 20 degrees, which corresponds to about 70 degrees of abduction of the foot as seen clinically, then we are ready to correct the equinus deformity, which is typically done in many instances with the help of a percutaneous tenotomy of the tendo Achilles. So here are a few examples, a few more examples. This is again a baby who came to us on the second or the third day of birth, and here he is at different stages with a completely corrected clubfoot deformity casting. Yet another child with in the first few days of birth, and the method of examining their function by seeing the children squat is the most effective way of figuring out that the equinus has been completely corrected and that even dorsiflexion is. So this is typically how the casts are applied. You can see the cast is applied till the groin. The cast is applied very gently. There are no pressure points. The finger or the thumb does not stay at one point on the foot or on the leg for more than a fraction of a second or for more than a few seconds in order to prevent pressure sores. Of course, the parents do not tolerate casts that come off or casts that create pressure sores or ulcerations in the child's foot. If the cast comes off, somehow the parents lose confidence in the method of treatment and in the surgeon, and the art of applying a plaster cast for the child is something that can only be learned with experience. As a matter of fact, Dr. Ponsati was overheard remarking at a conference to a colleague at the age of 81 years that he had just begun to apply a very good plaster cast after more than 50 years of applying casts on these babies. So here are these kids with their full correction. The foot usually looks reasonably normal. One does not assess the foot with the help of X-rays. If the foot is plantigrade and looks reasonably normal, then it will do. So some more examples of young kids who came to babies. Now, the essential ingredient of the correction with Ponsati method is post-operative bracing, which is continuous for the first 3 to 4 months, except for 1 hour in a day where the parents are allowed to bathe the child and massage the child's feet, etc. And then thereafter, every time the baby has to wear the brace during nights and whenever he naps during the day. The bracing is an essential component, and it's understood that with more levels of education in the parents, bracing compliance is high, and therefore the risk of recurrence of the deformities is much. So we have had the privilege of treating more than 500 babies since 2001. Surprisingly, in our experience, tenotomy has been done in only about 60% of the cases. Actually, contrary to Dr. Ponsati's experience, where he has spoken about almost 70% or more. And we have had to perform soft tissue releases only in 18 cases in all these years for different reasons. Most of the time, the soft tissue releases were done for the atypical club feet or the ones who presented to us with arthrogryposis or myelomeningocele, or the ones with extremely tight creases in the skin. Only in 2 or 3 instances did the parents insist that they are unable to follow up for serial casting for logistical and practical reasons, and they demanded a soft tissue release because it would ensure a single stage surgery. Now, the interesting thing about soft tissue releases is that before the Ponsati method, from the year 1989 till the year 2001, we treated an almost similar number of feet with a few serial casts and then always a posterior Attenborough subtalar, Attenborough soft tissue release. We have never performed a posteromedial Turco release, as in our experience it is unwarranted and uncalled for. It is not only not necessary for correction of the deformity, but it also leads to stiffness and arthritis in the hindfoot and the midfoot joints if it is performed as an extensive soft tissue. So we've had a few rocker bottom feet. We've seen recurrence in a few feet, but in the majority of cases have experienced good to excellent. A few words about foot. This is a baby who came to us and we treated with serial casts. And as you can see on the photograph on the right, this is a rocker bottom. That means the foot gets corrected at the level of the midfoot, and the x-rays of this child can be seen. Sometimes this happens because we are unable to apply the forces in the right direction, maybe if the child is struggling or just it's a technical error. So solve this problem and we applied a reverse Ponsati cast. Notice here the very nice molding in the plantar area of the foot. And again, so the casts are applied serially. We keep the child in equinus, that is, we match the equinus of the hind foot by bringing the forefoot down and keeping it like that for a few weeks and then try both deformities together. And here is the child after complete correction of the rocker bottom deformity after 3 to 4 serial casts. We may use the braces in the opposite direction in some cases for a certain duration to also prevent and mitigate the effects of the rocker bottom. So the Ponsati's principles are based on kinesiology of the subtalar joints and physiology of the ligaments. That is, one is to remember that we are not trying to achieve correction with every manipulation. The manipulation is facilitated by the act of casting. When the feet are casted, the ligaments relax and soften, and hence every time we remove the cast, we are able to gently increase the level of correction just a little bit, and therefore no force or very little force is. So this is an animation which explains how first we supinate the forefoot and then abduct the forefoot, which then allows the calcaneum to abduct from underneath the talus. And then finally, the equinus is corrected. This is the same thing seen from behind. So the hind foot is in a lot of supination. Initially, we match the supination of the hind foot by supinating the forefoot, and then we abduct the forefoot so that the calcaneus abducts. That is, the tuberosity of the calcaneum moves away from the lateral malleolus. As you can see, the orientation of the calcaneus also changes once we abduct it. So it goes further away, and then we are able to correct the equinus by carefully manipulating it with a gently hooked index finger to bring it down. Or else if it is too tight, then a tenotomy of the tendoachilles is done, which helps us to. So a couple of tips that we have found very useful over all these years that we are using it. We always cast the baby on the mother's lap. The tenotomy is also done on the mother's lap with the help of a few drapes, and the mother is taken into confidence. Frequently the child is nursed, and maybe a little bit sedation may be given. And sometimes we use the last cast with a little less flexion of the knee. So now coming to a few older ages where clubfoot presents from age 2 to 20, we have successfully used the Ponseti casting method followed by limited posterior soft releases. This is an example of this young lad at the age of 3.5 years with this severe deformity. First started with the Ponseti method, and then the final equinus could not be corrected, so we ended up with a little limited posterior lateral soft tissue release, which helped us to completely correct the deformity. This is another young boy, about 3.5 years of age, with a severe clubfoot deformity. And at the end of a few casts, we performed a very limited soft tissue release done posterolaterally. Because as you saw in the animation, if the calcaneus has to abduct and the tuberosity of the calcaneum has to move away from the lateral malleolus, the calcaneofibular ligament, the posterior tibiofibular syndesmotic ligaments, and the capsule only are released. A little release is also performed of the tendoachilles, and with due care to the posterior soft tissues, if needed, the tibialis posterior and the flexor digitorum longus tendons are also elongated by a Z-plasty. And then, of course, bracing is done for. What about this 20-year-old who has this untreated clubfoot? It may seem like an impossible task, but very simple. And these are his X-rays. We could use the Ponseti method, apply serial casts, and after about 5 to 6 casts, which were kept for about 3 weeks, we could get away by very limited posterior soft tissue release to give him a completely corrected foot, which is pain-free, plantigrade, and stable. And these are his X-rays. So the Ponseti method works regardless of the age of the patient, and casting should be given a good trial. There is, in my experience, there is no need to perform a lot of surgeries that involve arthrodesis and resection of the midfoot, etc., because proper application of the Ponseti method with casting can do the job. Of course, in older children and in young adults, the thing is to use um, reinforced casts with polyester casts so that they don't wear out, which is essential to maintain. The Ponseti casting we have found works really well, say without the need for soft tissue releases also. Here is this child who had these casts. You can see the number 7 on the 7th cast. The interesting thing about this is that we need not apply a cast above the knee in these children. What that does is it allows them to walk about and go to school. The parents don't have to look after the kids so much. As long as they don't soil the cast from inside, they're fine. They're walking about, and the initial cast with equinus is built up with appropriate footwear, so the child is walking. And it does take much longer than it does in infants, but it really works. And it may take 2 to 3 weeks per cast to allow adequate softening of the ligaments and the capsuloligamental structures in order to get a good correction. And here is this child with a very good correction and correction out of equinus, as well as 5 to 10 degrees of dorsiflexion as well. So another child with Streeter's syndrome, she has congenital constriction bands, and you can see here the amount of correction that we could get with serial casting alone, release of the bands. So beyond 4 years, sometimes we have the need for Ponseti followed by the Elizarov method. This is a 5-year-old with a recurrent clubfoot following soft tissue release. So the Elizarov fixator or any external fixator in our experience is reserved for those cases in which previous surgery has already been performed, which has led to fibrosis and stiffening of the hind foot. As in the lad, this is his pre-op X-ray. And then we have performed the Ponseti method for we have applied several casts, and the hindfoot equinus is a little stiff because of previous surgery. And so we apply the Elizarov apparatus, uh, which is the beauty of this method is that the fixator stays on the leg for an extremely short, and hardly in 4 weeks we can achieve a good correction and get rid of the apparatus back in a cast to give a good result like so. Now, in older children and in those feet in whom extensive posteromedial soft tissue releases have been performed, or the syndromic club feet presenting to us at older ages, the Elizarov fixator can be used using the Ponseti principles, very adhering to the Ponseti principles exactly get you a good correction. This was the kinesiological sequence we came up with in the year 2002, in which we have a construct for creating supination of the forefoot. We have a special talus wire, which is an olive from the lateral side to give counter pressure on the neck of the talus so that the forefoot can be abducted very effectively. And then we allow the calcaneus to rotate into abduction. And then finally, we correct the hindfoot equinus with the motor rods applied in manner. So this is the correction, an example of a 7-year-old who had a previous soft tissue release with a recurrence of. So you can see his heel does not touch. And here he is with the Elizarov fixator. So essentially fixation consists of 2 rings in the tibia, one half ring in the forefoot, one half ring in the hind foot. You can see at the end the motor rods which are correcting the equinus deformity are angled very significantly away, and I will explain that to you in a bit. The direction of the motors is a very essential ingredient in accuracy. So you can see they are tangential to the talar dome and they are always perpendicular to the moment arm. The moment arm is a imaginary hypothetical line that joins the center of rotation of the ankle joint to the point where the forces are being applied. So at all points in time with the fixator on the leg, these motor rods are to be kept perpendicular to the moment arm. So therefore we have to change the montage and change the direction of motor rods in order to very good correction. So this is the push construct in which the rods are tangential to the talar dome because the talus has to rotate as well as glide into the ankle posteriorly because the talus is broader posteriorly. So at any point in time, we need to remain tangential not only to the talar dome but perpendicular to the arm. This animation should explain this is the center of rotation and the moment arm is the blue line. If we apply the forces exactly at right angles, every distraction force resolves itself into two vectors, F1 and F2. The F1 vector, which tends to push the ankle in the front, turns out to be 0 if we are perpendicular, and the force F, which is effective, the force F2 is applied remains effective in the direction of the force, and therefore the ankle is always constrained and we get a very. If, however, we are to apply our forces as is illustrated in many books in a direction like this, which is almost vertical at an angle theta to the perpendicular, then the distraction forces F resolve into F1 and F2. And the F1, which is an anteriorly directed force, with the help of these calculations, anteriorly translates the ankle and causes it to sublux, or it causes it to over distract or crush into the ankle joint rather than accurately correcting. Hence, this is a construct we came up with. This is the moment arm vector method of correction of equinus deformities, which we use in the club feet and also in equinus deformities due to various other reasons like post-traumatic contracture, etc. And we have performed more than 150 of these, and this hypothesis has been borne out by the accurate correction in all of our patients. So here he is, this child in a car, and these are his x-rays. It's a very good sphericity of the talar dome which is maintained, the ankle joint maintained, and this is his clearance. And here you can see he's able to squat with a very good amount of dorsiflexion exceeding 25 degrees. Another young lad like so also has the Ilizarov fixator. At a younger age, the fixator is well tolerated. The children can walk about merrily. Very good correction of their deformities. Um, Unfortunately, this video doesn't run, but suffice to say that it doesn't cause them much discomfort. And here is this child with full deformities and an X-ray which shows the sphericity of the talar dome is retained and the relationship of the fibula to the tibia is also retained. If excessive forces are applied during correction, then it can flatten the talus as well as posteriorly translate the lateral malleolus, that is the fibula, and this is an iatrogenic deformity. The flat top talus and the posterior translation of the fibula are deformities created by the surgeon, and this should not be seen, and we can see that very well corrected. So therefore, I repeat, the sequential correction with external fixation like the Elizarov consists of initially forefoot supination, then forefoot abduction, counter pressure on the neck of the talus, calcaneal abduction, and equinus. Um, this is young lady, aged 20 years, uncorrected clubfoot, very severe, and this is her X-ray. So we can perform soft tissue distraction if the talar dome is spherical and is not already flattened. If the talar dome is, however, flattened, then what they need is an osteotomy. So this young lady had the Elizarov fixator, the block of two rings in the tibia, one hind foot half ring, one forefoot half, like so. To allow the calcaneus to abduct, we have to keep the free. And therefore, in this photograph, you can see that though we apply the hind foot ring, it is not connected to the tibial rings, which hence allows it to abduct out from underneath the talus. And there is a temporary connection attached to the forefoot ring, which is kept loose on the lateral side. And the distraction out of abduction is performed on the middle. And these are our x-rays with the appropriately angled hind foot. You can see that the motors are tangential to the tail. And here is her correction, her X-ray with a very good ankle, sphericity maintained, the ankle joint space is maintained, the cartilage is not damaged or cracked. And here's a clinical with. We can also perform a pull construct in which we pull from the anterior direction rather than push from behind, where the pull is parallel to the pull of the tibialis anterior. So as you can imagine, in the normal foot, the tendo Achilles and the tibialis anterior are almost parallel in their actions, and we can this direction, as in the case of this young lad who had myelomeningocele, and we corrected his forefoot deformities. Initially, you can see this, you can see a close-up of the construct showing how the abduction is going to be corrected. And here you can see the anterior rod with the distraction flag which is set up, and the posterior ones are parallel but more in a passive mode. Is the anterior one to give him a very good correction. So we have had a few complications, like one instance of lower tibial physeal separation, some calcaneal thickening, wire cut through in soft bones, and mild recurrence due to. But what we haven't seen are the serious complications of subluxation of the ankle, crushing of the cartilage, or over distraction or foot. This is a 34-year-old mother of four who has corrected severe rigid with fortunately a spherical, at least not flattened. So here is her fixator. Again, the two rings in the tibia, one in the hind foot, one in the forefoot. Here, instead of just using a dropped wire in the talus, we have used a half ring in order to better transmit our force. And here is her correction with dorsiflexion of 20 decibel, good correctly, and also the ability to squat, which denotes a good amount of flexion. So I end this by reiterating with an animation. This is the supination of the forefoot performed as a force couple, and then abduction of the forefoot is done through a dropped motor from the tibial rings. The hindfoot ring is kept free so that the calcaneus can abduct, and we don't have to take the patient back in the OR because we do not go back and add a hindfoot ring or some such. And then finally the equinus is corrected. You can see partially, then we change the direction of the motors to remain perpendicular to the moment arm to achieve the complete. And this is another view of the same. This is the forefoot supination with the force couple. There's the medial rods are pulling it up, the lateral ones are pushing it down. View from the top showing forefoot abduction performed, which allows the calcaneus to abduct out from underneath the talus, move away from the lateral malleolus till the AP talocalcaneal angle is 20 degrees, and then we can fine-tune the correction by inverting specifically the calcaneus and finally correcting the equinus with the moment arm vector positioning of the rods to achieve a full correction. Of course, X-ray control helps us to do this and to prevent problems. So these are a set of three animations which show us what will happen if we first correct abduction, which is on the left, versus correcting eversion, or if we first correct the equinus. And it's the best way to do this is understanding how the Rubik's cube is corrected. Unless you follow the sequence, you cannot end up with a complete solution to the puzzle. And the solution to the puzzle of clubfoot lies in the Ponseti method of correction. It was indeed my great privilege to spend an entire week with Professor Ponseti at the age of 89 at the University of Iowa Hospitals. This is April 2002. I learned a lot from him. I learned a lot about gentleness, about applying science, about the role of casting, and about how we are overdoing surgeries in many instances and in many diseases. I had the privilege of not only learning and seeing him at work, but also of attending a couple of musical concerts with him and learned a thing or two about life from him. I will end with this small case which shows osteotomy correction. This is a 28-year-old gentleman with a rigid flat foot, but his talus has got a flat top, and hence he's not a candidate for soft tissue. And here we apply the method of correction in which we performed a V-shaped osteotomy. There's a hind foot osteotomy through the calcaneum, and the front limb of the V goes through the talus and the calcaneum. And we use these olive wires to ensure that forces are well applied. And here is the X-ray which shows that the talus is exactly where it was, and the rest of the foot, the hind and the are corrected around it. So thank you for your attention.